I would like to introduce our presenters for today. So we have the pleasure of having Graham Atkins and Amelia Cullinan present to us today on the prognostication and goals of care in the COVID-19 pandemic. It's all yours.
Okay, I think I'm up first to talk a little bit about prognostication and particularly prognosis in severe disease associated with COVID-19. I'm going to go first, and then Amelia will talk about communication and goals of care. Next slide. I believe neither of us has any conflicts of interest. Next slide. So I'm sure many of you will have seen tables like this that talk about the case fatality rate and how high that can be when age increases. Next slide. I think what's more relevant, particularly to my practice, is what happens to the people who are in the intensive care unit. So this is UK data that's fairly up to date that shows about 20% of people admitted to ICU in the UK with COVID-19 have died, about 20% have been discharged alive, and about 60% of people we do not have accurate data yet. I think this is an interesting slide that it certainly tells us there is a length of time that people spend in the ICU with COVID-19. And certainly in my recent experience, having people on ventilators for a couple of weeks would not be unusual, and another week or two in hospital also not unusual. So I think as time goes on, this data will sort of become much clearer. Next slide. I think although those kind of tables and data sets are helpful for thinking about what prognosis is like for a population of people with COVID-19, what my patients are interested in are what is their individual prognosis. And having just come out of a week in our COVID ICU, I am more and more convinced that the illnesses associated with COVID-19, both the critical illness that you can get and the ARDS that you get, is pretty similar to regular critical illness and regular ARDS. And with that in mind, I think the standard prognostic tools that we use are likely to work well when coming up with a prognosis for individuals who are critically ill. That's my opinion, but there's also some data from the Lancet to support that. This is a Chinese study of 200 patients. They predicted a mortality of about 20% and mortality was about 25%. So for the severity of illness, the prediction model was pretty good. And the type of prediction model we often use to predict ICU mortality is something called the SOFA score. Next slide, please. The SOFA score is basically a way of looking at a number of organ system functions or impairment in a number of organ systems. You plug in the numbers and it will give you a score. So the things that are important are how well are your lungs working, all on the top left. There's a measurement of platelet function to look for bone marrow suppression, conscious level. Then we look at liver function, renal function, and your blood pressure and how much support you are requiring to keep your blood pressure in the normal range. That'll come up with a score. Somewhere around a score of 5 indicates about a 20–25% mortality. Somewhere around a score of 10 indicates a 50% inpatient mortality. Okay, next slide. A shortcut for thinking of this is the most severe manifestation in terms of pulmonary illness from COVID-19 is ARDS. And if you look at the most recent high-quality study on ARDS called the EOLIA trial, they looked at patients with really bad ARDS, so bad that no matter what you did with the ventilator, you couldn't achieve adequate oxygenation. Those patients had a mean SOFA score of about 10.5. So you'd expect about a 50% mortality, and sure enough, they had about a 45% mortality. So this prediction model seems to be pretty good for people with bad ARDS. You could also use this as a shorthand. So people with really bad ARDS have about a 45–50% mortality, and these were younger people, 55. Often our patients in the ICU will be older than that. But it's rare that we have cases of ARDS that are this bad. So if you just had to ballpark mortality, most of the patients with ARDS in the ICU, I think, will have mortality somewhere between 25 and 50%. Next slide. But I don't think mortality is the only important outcome here. And looking at their current organ system function is probably not as good as trying to incorporate some data about what their functional status was like pre-hospital, and thinking about what treatments are available to try and improve their overall condition. Next slide. So what I typically do when I'm seeing patients in the ICU is think about their level of illness, think about their SOFA score, think about their pre-hospital function, think about available treatments, and try and come up with an estimate of what are the chances of a full recovery, what will it take to get to a full recovery, what's the most likely outcome, and how likely are prolonged stays in the ICU for things like a tracheostomy, dialysis, feeding tube, nursing home. And I think this is really important because you could have somebody very sick in the ICU with a 50% mortality, but only a 10% chance of a full recovery. And the other 40% is some combination of things like long-term ventilatory support, oxygen, dialysis, nursing home residence. And many of the patients and families who I interact with would find that level of disability an unacceptable long-term outcome. So I think it's important to estimate as best you can, not only the chances of mortality, but if someone is able to survive this illness, what does that survival look like? And helping us communicate those thoughts and those estimates to the family is really where palliative care can be fantastically helpful. Next slide. So I'm going to hand things over to Amelia.
So thanks, Graham. So I think what we're seeing is that prognostication is inherently uncertain. And it's not about being right. It's about helping patients and families to prepare for the best case and the worst case, and thinking about those functional outcomes. So being prepared means not just knowing what's possible, but also having contingency plans informed by what's important to our patients. So this talking map that you're seeing here is what I'm going to be presenting, and it is available on Connect and will also be sent out after the talk. So this talking map helps us to efficiently and compassionately learn how to deliver goal-aligned care to our patients. It's adapted by maps created by Ariadne Labs and VitalTalk, two national organizations focused on developing scalable tools for serious illness communication. The front page has the map that I'll be focusing on. The second page has skills for responding to emotion, and a second map to be used in the hopefully now unlikely event that we will have to ration healthcare resources. So to begin our conversation, we set the stage by acknowledging our patient's emotion and our own emotion, provide a context for what we want to discuss, and create safety by asking permission, because they can say no to having this conversation. Now you might be saying, well, what if we have to make decisions right now? Well, then what I say to my patient is, who can I speak to on your behalf if this is a conversation that you don't feel you can have right now? Next, we need to assess what our patient or their family knows so that we can deliver the information that they need and avoid repeating the information that they already have. And again, create safety by asking permission to give prognostic information, which allows the patient or family member to steel themselves for what's coming. And then we need to share information, prognostic information. So if this map is being used prior to a patient getting sick with COVID, we're giving a little bit of an overview. So most people who get COVID get better on their own. However, people who are older or have other health problems like yours can get very sick and may not survive. The treatments that we use to try to help people live, like breathing machines, may not work. If they do work, recovery from the illness is uncertain. We really hope that you don't get the virus, but it is important to prepare in case you do. So we're really emphasizing that hope language, which aligns you with the patient, but also emphasizing the need to be prepared. For patients who are sick with COVID, we could stratify them by a normal or high risk. So for a normal risk patient, you can name uncertainty about how COVID affects people, but normalize that we're asking everyone to share what would be important if they got sick and couldn't speak for themselves. Or if you have someone that you're really worried about how they're going to do because of your high-risk condition, and you can label what you think that would be. If you get really sick, I worry that treatments like breathing machines or CPR are not likely to work or get you back to the quality of life that you had before. Now, that can be really hard information for people to hear, and so we really want to emphasize that you need to expect and respond to the emotion that people have after hearing tough news like that. So you want to make sure that these skills, this mnemonic is nurse, it's got a handful of useful phrases to use. You can use them in any order, and you can modify the language to fit your style. So if your gut tells you, for example, it feels right to say this situation sucks rather than this must be overwhelming, then follow your gut, right? Make it fit your style. Next, we, in light of the prognostic information that we've just given our patient or decision maker, we want to know what's rising to the surface to them. And if you don't elicit much with the most important question, I suggest that you deepen it by asking what they're worried about. Next are critical abilities. So what abilities are so critical to you that you can't imagine living without them? I will often give an example. So some people need to be able to do things for themselves like toileting or bathing in order to say life is worth living. Other people need to interact meaningfully with loved ones, and others say life is life no matter the quality. How about you? This piece of information is really critical to guide future healthcare decisions. So for example, if we have a patient who say they wouldn't want their life prolonged if they couldn't get out of bed and do basic tasks, and then gets COVID and is being managed by Graham in the ICU, if Graham doesn't think that he's going to get back to that quality of life, that makes it a lot easier to be able to make a recommendation to transition to comfort-focused care, because you know that they're not going to get back to what's acceptable to them. Next, trade-offs. What a patient is willing or not willing to put up with in order to live longer helps us to talk about treatment preferences without getting into that Chinese menu conversation of, do you want a side of dialysis? And how about some pressors with that, right? It really kind of just opens up a spectrum of choices that people might make and lets a patient align themselves where they would place themselves. You're looking for pre-existing preferences with this question. If you want to get into a shared decision-making conversation, you can from this point, but the purpose is really just to elicit pre-existing preferences. So you might be saying, well, what about CPR? So before I begin a conversation like this, in which I plan to talk about CPR, I will actually go to MD Calc and calculate the GOFAR score. GOFAR basically helps you to determine the likelihood that a patient, if they code, will have meaningful neurologic ability, have their full cognitive abilities at hospital discharge after a code, which is really what patients care about. They don't necessarily care about just surviving in a vegetative state. They want to know, am I going to leave the hospital and still be able to live my life? So if you squint, you can see that this is a 75-year-old patient, and they came in with a medical non-cardiac diagnosis, which would be what you would put if they had COVID, who has altered mental status due to hypoxia of 85%. So if this person codes during a hospitalization, he will have a 1 to 3% chance of surviving to hospital discharge neurologically intact. That's really powerful information to be able to give to a patient to help them make some decisions ahead of time about whether they would want CPR. So I will calculate that ahead of time. I'll explore prior conversations with the patient. Have you ever talked with anyone about your wishes for CPR? And then ask permission to share these outcomes. Now, you may still have a patient who says, okay, I'll take my 1 to 3% chances, but that's an informed patient making an informed decision. Next, it's not enough that we know what a patient wants. We need to make sure that our patients' decision makers know all of this stuff that we've learned also. And then we close with a recommendation. So I've heard you say that blank is really important to you. Keeping that in mind and what we know about your illness, I recommend blank. How does this plan seem to you? So let's practice coming up with a plan. So let's say that 75-year-old that we just calculated the GOFAR score with, he had previously excellent functional status, hypertension, diabetes, admitted with COVID. His SAT is, let's say, 89%, altered mental status, conversation with his spouse. She says that for him, he would not want to live longer if he lost the ability to think for himself and recognize and interact meaningfully with loved ones. And she said that he'd be okay with trying a ventilator to try and survive COVID, but let him go if he's going to have to live on machines for the rest of his life. And she said no to CPR. He wouldn't want to live if his brain was all messed up. So if I was in an outpatient setting having this conversation with someone, I would actually create a POLST, which is provider orders for life-sustaining treatments and has the same weight as an out-of-hospital DNR. I would specify that no, this person doesn't want CPR, but then I would say that he wants full treatments, meaning that we are not going to code him if he has a cardiac arrest, but we are going to do everything up to and including intubate him to try to get him through this illness. You can use your inpatient orders to be able to denote this in a slightly different way, but I wanted to be able to share that with you. You also need to document it, and this is the template that's available within the DH system. It's .COVID goals, and I'm happy to share it with folks that are outside the DH system. What if a patient says they don't want hospitalization? Well, then you need to make sure that they have access to meds to keep them comfortable. And so at this tiny URL link at the bottom of the screen, our team has put together a list of not just communication guides, but also inpatient and outpatient symptom management resources. You'd obviously also want to make sure that a patient who wants to stay home if they have COVID, that they have access to hospice supports. In closing, I wanted to just reference these two resources. These are the folks who created the original talking maps that I've adapted. There is a wealth of provider-facing and patient-facing tools on those sites. And that wraps us up.
Wonderful. Thank you, Graham and Amelia. That was wonderful.